This bill has been, the Health and Care Bill has been a long time in the making, and it is quite revolutionary. And it will mean, for the first time since the creation of the NHS, that the government is putting forward a set of reforms in which the state continues to fund healthcare in England, but largely abstains from being involved in its organisation. And the reforms hand over most power and decision-making to public-private joint ventures without statutory duties, and break decisively with the Beveridge model of a universal and comprehensive and accountable public service. And of course, many have been taken in by the official narrative of the bill around integration and flexibility. But if you sort of are not taken in by the positive sounding words and read the bill and the NHS England's guidance, you'll see, and continue the thought process, you'll see that it's got virtually nothing to do with integrating health and social care, and the flexibility is a cover for discretions and the absence of statutory duties and the dilution of our enforceable rights to publicly funded healthcare. So in more detail, the bill completes the detachment of funding, planning and provision from local areas and local people. England is being divided up into 42 integrated care systems, which are only partly statutory and partly and perhaps mostly non-statutory. The integrated care boards, not the systems, the boards, just like the clinical commissioning groups that they will replace, will be membership based, and each ICB will commission most health services for the group of people allocated to it by rules to be made by NHS England without parliamentary process, not for local residents. The CCGs, of course, are already membership organisations, but at least Parliament decided in 2012 who they were responsible for. They're not doing that this time. And they're also only requiring ICBs to have core responsibility for the people allocated to them. And this is a new concept that's not been questioned. But it echoes the definition of health maintenance organizations in the US, which provide basic and supplementary services to their members. And again, unlike CCGs, an ICB will not be obliged to commission emergency services for everybody present in its area. And also, unlike CCGs, tellingly, ICBs will not have to have the letters NHS in their name. Private companies will be able to sit on ICB boards and their committees, but ICBs are a veneer. I think that's the important thing to say. And in fact, as Lord Andrew Lansley said in the House of Lords, the real power will lie with the non-statutory provider collaboratives. And these are joint ventures of public and private providers that are not mentioned in the bill, with no provision for their transparency, accountability, or membership. And ICBs will be empowered to delegate functions to providers and give the providers discretions in their contracts, which will be long-term and strategic. And they'll also be able to have the budget devolved to them, and they'll decide what, where, and how services will be delivered. And there will also be these non-statutory place-based partnerships described by NHS England as the foundations of integrated care systems, but they again will have no statutory functions, nothing about governance or accountability in the bill in relation to them. So those, if you like, are the main high points of detail, the fundamental changes to the system. And I'll hand over to Alison now to say something about implications and what next.
What's the big message from this? I mean, this is 30 years of incremental changes, but it's really probably the final step towards the US HMO style system. And the evidence for that, I just heard some of your conversation, is the fact that so much of the health service is now penetrated by large American corporations, many of which combine insurer and provider functions. So you were talking about Operos and Centene. So 30 years ago, they would never have been couldn't penetrate the NHS. The structures weren't there for them to select services or cherry pick patients, or indeed to have a two-tier mixed funding system. So what's likely is going to happen is you're going to have more and more basic levels of care services, a basic, as Peter's described it, core services, basic services, and then people will have to top up for their services. And the evidence for this is already obvious if you look at some of the large teaching hospital foundation trusts. If you recall, in 2012, they were able to raise from, ever since 2012, trusts have been able to move towards generating up to half of their income from private sources, 49%. And so if you look on some of these trust websites, the Cancer, Maudsley, Marsden, Moorfield, UCLH, they're advertising now services, as are some of the GP practices as well. So everything is now in place for this big switch, as it's, of course, it won't be a massive switch overnight. It won't be like the NHS being created. This has been done without public knowledge. The bill is very technical and uninterpretable unless you've followed 30 years of legislation, because it's building on what's gone before. But as well as that, as Peter has said, so much is happening outside of the bill with these non-statutory bodies or non-statutory groups. But that is where all the power will lie. So it's really bad news. And there will be mixed funding system. There's going to be increasing inequalities. There's going to be decreased access to care for everybody. And the providers, it's a bit, if you think about mental health services, if you've got a severe acute mental health problem in the UK, and you need hospitalization, you are not going to ever find a local hospital. You have to go on the provider websites and they will tell you in which area of the country there are some beds available, and people will have to travel. So this isn't about patient choice. It's much more about patients will have less and less choice. So it's really, I think this is the end of the Beveridge model, or the Bevan model, if we'll call it the Bevan model. Along with all the principles and values. I mean, Scotland and Wales aren't going down that route. But I think it will be increasingly difficult given their size. And there are big questions about what happens to people who live and use access services in England, for example, from Wales and Scotland, because there's a lot of cross-border flows, and vice versa. But the undermining of the entitlements that we've seen, for instance, for migrants, for people, for refugees, for asylum seekers, this gradual erosion of entitlements is now going to be, we're going to be facing it. And COVID has been very much a cover for all of these things to happen. And as you know, the government's been pouring billions into private hospitals for which it's had for which it's had nothing in return, and is continuing to extend those contracts. So, as Peter said, Parliament's standing back. It's largely abdicated all its responsibility, and the decision-making power is being handed over to unaccountable entities, and they're going to have a lot of flexibility to determine which services you get and which will be charged for. And of course, it's a repeat of lots of other privatizations that we've seen, for example, long-term care. So I'm going to finish there. What can you do? Well, I think you're a group that's very well used to thinking about what you can do. Something that Peter and I did was some of the people in Camden approached the councillors actually had a deputation to the local authority. So I think that's really important that you hit all your local authorities, and perhaps that's something that the SHA should be doing in every area, is the if they've got any councillors or Labour councillors or any way in, they should be sending deputations. And Peter and I have put, it's on my website, but we've put that briefing note, which is clear as clear can be. So that's one thing. Clearly, the Labour Party, although the Labour Party seems to be backing this bill all the way, and as Peter has said, there's been very little scrutiny. They didn't even pick up the fact that not everybody in the area would be entitled to, living in an area would be entitled to emergency services. So it's a big public campaign. It's a bit like, I don't know how you get this going, because it's very interesting over the vaccine mandates. That was an extraordinary campaign for healthcare workers. And if only we could have, I've actually spoken to that group, and you know, if only we could get that same energy and urgency behind that campaign as the one that opposed the vaccine mandates, and looks like it's been doing it quite successfully, although they're going to come in through the back door. But that's the kind of level of you know, people gut feeling and reaction, and you know, that we need.